Good afternoon. Welcome to Grand Rounds. Today we're going to hear from Dr. Brandon McMahon. Brandon is an associate professor of medicine in the division of hematology oncology, or BMT, right? in BMT hematology? Yeah, or oncology. Okay. He went to college at Boston College, where he graduated summa cum laude and Phi Beta Kappa, and had a whole bunch of other honors while he was there. Went to medical school in upstate in Syracuse. He graduated AOA. Then he did his residency, his chief residency, and his fellowship at Strong Memorial in Rochester. And then he joined the faculty at Northwestern in 2007, and he stayed there till 2016, where he was when he was recruited here. It's interesting to look at his CV that every single year that he was at Northwestern, he won a medical teaching award. It just is repetitive, year by year by year, the same award. So that's very impressive. And he's won one here in his first year here. When he was at Northwestern, he was the director of the Hem/Onc Fellowship Program and also directed the anticoagulant services. He's on the guideline panels for the National Cancer Center Network for both myeloproliferative neoplasms and venous thromboembolism. And today he's going to talk to us about myeloproliferative conditions. His research interest is in clinical trials in myeloproliferative neoplasms. So we're looking forward to it. Thanks.
Thanks so much. Can you guys hear me okay? I can't really tell. Okay, great. Well, thanks for having me, and thanks for giving me this opportunity to talk about this class of diseases. This is definitely a particular interest of mine, both from a clinical and research perspective. There's, the BCR-ABL negative MPNs are, I think, a fascinating group of diseases. I kind of have to think that, since this is what I've chosen for my focus on my career. But I do think it's a very interesting class of diseases. There's no way I can do it justice in 45, 50 minutes. So I thought that the best way to do this is to just to give you a nice overview of the pathophysiology of the diseases, how these patients do, what sort of complications they have, and how we approach treatment. Like I said, there's no way I can really do it justice, so certainly if there are any questions, we'll hopefully address those as well. I am going to start with a clinical case and use that case to illustrate the different features of the disease, but I'm just to give you a framework as to what we're dealing with. So the myeloid malignancies, while they share a lot of features, there's a lot of overlap with the myeloid malignancies. They are definitely distinct diseases, and so the WHO classification in 2016 classifies them as such as you see here. So you have myelodysplastic syndromes in their own bucket, acute myelogenous leukemia, and then you do have MDS-MPN overlap syndromes, which again, at least through the most recent WHO classification, are its own class of diseases. Then what we're focusing is on myeloproliferative neoplasms, and those are further broken down into those that are Philadelphia chromosome positive, so BCR-ABL positive, and that's specifically chronic myelogenous leukemia, and those that are BCR-ABL negative. And those are further broken down into those that are classical, so it would be polycythemia vera, essential thrombocythemia, and myelofibrosis. And then the non-classical, so chronic neutrophilic leukemia, chronic eosinophilic leukemia, and mastocytosis. So we're really focusing on, what we're talking about today is this corner here. We're really going to be focusing on the classic MPNs. So with that, I'll start with a clinical case. This is a gentleman who was referred to me by his primary care provider after he had 3 sets of blood draws that showed persistently elevated hemoglobin and hematocrit. He actually went into his primary care doctor for a routine, it looked like a fairly routine visit. He needed a follow-up on his high blood pressure and high cholesterol, needed his medications refilled. From a symptomatic standpoint, was actually feeling pretty well, had mild fatigue, but I think no less or worse than any of us sitting here today. In terms of his comorbidities, as I mentioned, he has high blood pressure, but that's been well controlled on lisinopril hydrochlorothiazide. Hyperlipidemia, he's on a low dose of atorvastatin. Otherwise, really not much of anything. He has a remote tobacco history. He has a 10-pack-year history of smoking, but quit 20 years ago, although he does tell me that he does smoke about 1 to 2 cigars on the weekends. Physical exam, again, fairly unimpressive, slight plethora, a little bit of ruddiness. I think some of that was biased by the fact that I knew what his labs were. He is obese. His BMI was over 30. I think it was around 32. And he did not have any palpable splenomegaly or hepatomegaly, although that was limited somewhat by his body habitus. The labs that I had when I saw him, he had a white count that was 5.5, normal differential. His platelet count, while normal, was on the higher end of the reference range of 395, and his comprehensive metabolic profile was normal, but his hemoglobin and hematocrit were elevated at 18.6 and 55.8 respectively. So this is how he came into me, and so the questions that come up are, well, what's it in the differential? He's a little overweight, he had been smoking, he's on hydrochlorothiazide. Are these the explanations, or do we need to go looking somewhere else? And what additional workup does this gentleman need? So elevated blood counts, elevated red blood count, platelet count, white blood count, it's one of the more common things that we do get consulted on, particularly as an outpatient. And there's a huge list of things that can cause this, which is great from this, keeps me in touch with my internal medicine side. Even though I've specialized this, it's good to still do a really good history and physical exam and really look for some of these secondary causes. So for erythrocytosis, not surprisingly, one of the more common causes for secondary erythrocytosis is underlying pulmonary disease, so COPD, interstitial lung disease, anything that would require supplemental oxygen. Obstructive sleep apnea is a common cause. Of course, smoking, especially active smoking, a big cause of secondary erythrocytosis. And then other things like an intracardiac or intrapulmonary shunt, plasma contraction, concomitant use of diuretics, high altitude, being at a place like Denver. These all make a cause of secondary erythrocytosis. There are a number of other things, not as common. We do see a fair amount with testosterone supplementation, but the others like elevated endogenous erythropoietin levels from something like a renal cell carcinoma or hepatocellular carcinoma, or high-affinity oxygen hemoglobins, methemoglobinemia, and mutations in things like von Hippel-Lindau or the EPO receptor, pretty uncommon. These are things that we start looking for when everything else is negative and the person's erythrocyte count is still quite high. For thrombocytosis and leukocytosis, the most common things are either acute or chronic inflammatory issues, so really bad infections or chronic inflammatory states like rheumatologic diseases. For thrombocytosis, actually, probably one of the most common things we see as a cause is iron deficiency. Iron deficiency is probably I would say, the single most common reason for an elevated platelet count that at least I see as an outpatient. Asplenia, either functional asplenia or patients who've had a surgical splenectomy, those patients are going to have a baseline elevated platelet count as well as possibly and probably an elevated white blood count. For leukocytosis, besides infections, two of the more common things we see, actually active smoking is a very common cause of leukocytosis. Usually it's predominantly neutrophilia, and the neutrophilia can persist for several months after the patient stops smoking. And then obesity is another common cause as well of leukocytosis. And again, it's typically neutrophilia, and oftentimes the neutrophilia is associated with an elevation in the CRP, indicating that obesity may just be another example of a chronic inflammatory condition leading to a reactive leukocytosis. So keeping these differentials in mind and knowing what this gentleman came in with, we did some additional workup for him. And the lab work, we had the CBC, as I mentioned, and the CMP. His peripheral blood smear was really fairly unremarkable. His red blood cells were slightly elevated, but the morphology was normal. There weren't any dacrocytes or teardrop cells, which is important to look for. His white blood count was normal. There wasn't significant dysplasia, and his platelet count was normal, and also the platelet morphology looked fine. The erythropoietin level, in his case, his endogenous erythropoietin level was low at 2. His echocardiogram had normal left ventricular and right ventricular size and function. There wasn't any evidence of pulmonary hypertension, and there was no evidence of intracardiac or intrapulmonary shunt. He had an abdominal ultrasound that showed normal liver size and architecture, no abnormalities with the kidneys. Kidney size looked fine. There were no discrete lesions. He did have mild splenomegaly at 16.5 centimeters. So with him, with the obesity, you'd say, well, perhaps he does have underlying sleep apnea, and so pursuing a sleep study would be reasonable. That may take a little while to get done, but in the meantime, especially with this erythropoietin level being suppressed, the question is what would be the next step? And I think most of us now are very aware of the JAK2 mutation. So we did send off the JAK2 V617F mutation, and his result did come back positive. So this gentleman has JAK2 positive myeloproliferative neoplasm, and because he's had an elevated hemoglobin hematocrit above what would be the threshold in the WHO criteria, he would meet criteria for classifying this as being polycythemia. Noting, of course, actually he really has erythrocytosis, not polycythemia, because his white count and his platelet count were normal, but the disease is polycythemia vera. So returning to myeloproliferative neoplasms, as I mentioned, there's a number of different kinds of these. You have chronic myelogenous leukemia, polycythemia vera, essential thrombocythemia, myelofibrosis, hypereosinophilic syndrome or chronic eosinophilic leukemia, and chronic neutrophilic leukemia. And then, of course, for those patients who don't meet those criteria, they're sort of thrown into this bucket of MPN unclassifiable. Mastocytosis used to be on this list. It's now in its own sort of separate category. But these diseases, as I mentioned, even though they're distinct entities and they do follow different courses for the most part, they do share a lot of similar features. They share the fact that there is an increased number of functional, mature, differentiated myeloid elements. So unlike leukemias, where you're overproducing immature cells that are not functional, for the most part, these diseases, you're producing cells that are more mature, and for the most part, they are functional. They're also associated with a specific acquired allelic mutation, and it's a driving mutation that ultimately leads to constitutive tyrosine kinase signaling. And because of this, patients share a lot of similar symptoms, and these include fever, weight loss, night sweats, itching. So these are symptoms that are very common among the different MPNs. And then splenomegaly is a fairly common feature of most of these diseases, particularly the three that we're going to be talking about today. And so we're going to be focusing on PV, ET, and MF, or myelofibrosis. A lot has been learned in the last about 10 to 15 years with these diseases, with the discovery of these specific driving alleles that ultimately lead to the clinical entities. So, as I mentioned, they're all associated with a specific driving allele. So you have a hematopoietic stem cell, that gives rise to a myeloid progenitor, and then the myeloid progenitor, based on different signaling, will give rise to the mature myeloid elements, and each of these myeloid elements are associated with a specific myeloproliferative disorder, or myeloproliferative neoplasm. And for each of the myeloproliferative neoplasms, there is a known activating mutation. So, for example, with mastocytosis, we have the c-KIT mutation. The classic example that really helped sort of drive this was the discovery of the Philadelphia chromosome with chronic myelogenous leukemia, the BCR-ABL abnormality. So for polycythemia vera, about in 2005, the discovery of the JAK2 V617F mutation really changed our understanding of the disease and how we approach it, and has given us a lot of information as to how these patients do, as well as helpful with prognostic information. Most of the patients are JAK2 positive. The remainder that are not, the small percentage that are not, will be positive for the exon 12. For central thrombocythemia and myelofibrosis, a good percent of the patients will be JAK2 positive, but the remainder, if they're not JAK2 positive, will likely be either positive for the calreticulin mutation or the MPL mutation. And we'll talk about this more as we go along here. So this just illustrates in a very simplistic way sort of what goes wrong. So under normal physiologic conditions, under panel A here, a cytokine binds to the cytokine receptor, stimulating the receptor and allowing the wild-type JAK2 to bind and become phosphorylated. That phosphorylation activates the STAT pathway and downstream the PI3K and AKT pathways, ultimately leading to activation of genes important for cellular proliferation and cellular survival. This is typically held in check by negative feedback through the suppressor cytokine signaling 1 and 3. But under circumstances where the patient has a JAK2 mutation, which would be B, the mutated JAK2 can bind to the receptor in the absence of a cytokine, become phosphorylated, and allow for the downstream signaling to take effect. There's evidence to show that not only does this happen sort of on its own without the cytokine, but this pathway with the mutated JAK2 can escape the negative feedback from the SOCS3 pathway. For those patients who have essential thrombocythemia or myelofibrosis that are negative for the JAK2 mutation, the abnormality comes with the MPL receptor. The MPL receptor, under normal circumstances, is the receptor for thrombopoietin. And so typically thrombopoietin binds to the MPL receptor and typically on a megakaryocyte leads to megakaryocytic differentiation and also proliferation, and ultimately leading to increased production of platelets. So for those patients who are JAK2 negative with ET or MF, they likely have a mutation in either the MPL or the calreticulin, which ultimately leads to abnormalities with this receptor, and the wild-type JAK2 binds to the abnormal receptor, again leading to the same downstream signaling that we see with the JAK2 mutation. So the calreticulin mutations, it's a relatively recent finding, about in the last, I think, 5 to 7 years. Under normal circumstances, the calreticulin molecule becomes associated with the MPL receptor, and then as the receptor matures and is being shuttled to the cellular surface, the calreticulin dissociates from the receptor, allowing for normal maturation and glycosylation, and so you get a normal receptor at the cellular surface ready for thrombopoietin to bind. When thrombopoietin binds, it activates the JAK pathway, the JAK-STAT pathway, and then you get the cellular proliferation, as I mentioned, typically through megakaryocytes. With mutated calreticulin, the problem is the C-terminus of the calreticulin allows it to remain associated with the MPL receptor. So as it gets shuttled, the MPL receptor does not mature normally, and what you get at the cellular surface is an immature MPL receptor that's still associated with calreticulin, and this interaction allows for abnormal stimulation of the JAK-STAT pathway, mainly the STAT pathway. So part of the reason why we see differences in clinical phenotype with these diseases is because of the underlying physiology, the pathophysiology. So as I mentioned, so the red is the mutated JAK2. So mutated JAK2 can bind to the MPL receptor, the EPO receptor, or the GCSF receptor, giving rise to thrombocytosis, erythrocytosis, or leukocytosis, respectively. And that's the reason why you get polycythemia. If it's predominantly erythrocytosis, it seems that the JAK, at least at that point in time, the JAK mutation, the mutated JAK2 molecule is interacting mostly with the EPO receptor. This also helps explain in part why some patients who have essential thrombocythemia that may be JAK2 positive, so they have the JAK2 mutation, but the phenotype, the clinical phenotype is essential thrombocythemia. A lot of those patients eventually will transform into manifesting symptoms and clinical phenotype more consistent with PV. However, for the patients who have ET or MF and their mutations are in the calreticulin or MPL receptor, those patients typically don't have erythrocytosis because of the way that the mutations work. For the MPL receptor mutations that lead to ET, those patients almost always have a simply elevated platelet count. With calreticulin, it's mainly elevated platelet count, but there is a little bit of association with the GCSF receptor, so those patients may also manifest a little bit of leukocytosis. In terms of how frequent these mutations are with the different diseases, as I mentioned, for PV, almost all of the patients will have the JAK2 mutation, probably 95% plus. And the remainder will almost about 3 to 4% will have the exon 12 mutation. So it's really, this is really the only mutation that we see with polycythemia vera. For myelofibrosis and essential thrombocythemia, it's about 35 to 50% of the patients will be JAK2 positive, with about 30 to 40% being calreticulin positive, less than 10% being MPL positive, and the remainder being what we call triple negative. Those triple negative patients likely have a driving mutation that hasn't been discovered yet, or they may have mutations in other either epigenetic modifiers or spliceosomes that are driving the disease. These patients typically do quite poorly, and we'll talk about that a little bit later on. So the underlying mutation does play a significant role, particularly with myelofibrosis, with regards to how these patients do. What we don't know is why some patients develop the JAK2 mutation. So this is an acquired mutation. This is not a germline mutation in most cases. There's a couple case reports of families having the JAK mutation. It's thought that there's some genetic data to show that there are inherited alleles in some patients that make them predisposed to the acquisition of the JAK2 mutation. And then the next thing that we're not quite sure about is why is it that some patients with the JAK2 mutation may manifest more of a myelofibrosis phenotype, whereas someone else may manifest more of an essential thrombocythemia phenotype. And that's probably because of host-specific genetic modifiers, either like epigenetics or, as I mentioned, acquisition of additional mutations in epigenetic modifiers or spliceosomes. And these are some of the additional mutations that are seen with these diseases. And acquisition of these additional mutations may also help explain why some patients eventually will transform from one disease category to another, particularly if they go from a PV phenotype to more of a PV/myelodysplastic syndrome or acute leukemia phenotype. These mutations, especially certain ones, for example, like ASXL1, we know is a bad actor, and it really is associated with a high risk for developing acute leukemia, a higher risk for developing acute leukemia. Now, central to the role of the disease is the megakaryocyte. So megakaryocytic involvement in each of these three diseases is very important. The MPL and JAK2, the abnormal MPL and JAK2 pathways involve the megakaryocyte. So for for the three driving mutations as well as the three different diseases, the megakaryocytes do play a key role. And when the megakaryocytes get activated, you end up seeing on bone marrow biopsy hyperplasia and oftentimes dysplasia, and as the disease progresses, they become more and more dysplastic. The megakaryocytes, when they're abnormal, under normal circumstances, they're very important for helping regulate hematopoietic stem cells, so that can get dysregulated with these diseases. It's also important. They're also important for local activation of TGF-beta1. Which can then lead to activation of fibroblasts. The fibroblasts then produce reticulin, and then you get myelofibrosis, and you can get frank myelofibrosis. Other things that the megakaryocytes do abnormally is they lead to abnormal neoosteogenesis. You have increased osteoprotegrin, which leads to reduced osteoclast production, increased osteoblast proliferation, and ultimately leading to osteosclerosis. There's a lot of other things that the megakaryocytes do in the microenvironment as well as more systemically, but they're a key part of the reason why patients don't do quite so well with these classes of diseases. So now that we have a sort of a basic understanding of the pathophysiology of the diseases, returning to our case, this 52-year-old gentleman with a new diagnosis of JAK2 positive PV. He comes in for follow-up and wants to talk about this. He went online, of course, He saw all sorts of different things. He saw he's going to die tomorrow. He saw if he just ate cinnamon toast, he'll be cured of this disease. He's heard all sorts of things. So he wants to know, well, what can I expect short-term and long-term? So we sit down, we talk to him about thrombotic and adverse cardiovascular outcomes, the potential for leukemic transformation, which is really the biggest concern that these patients have, and with that myelofibrotic transformation, and how does this affect his overall survival. So first we'll go through the issues with thrombosis and adverse cardiovascular outcomes. So patients with particularly the BCR-ABL negative MPNs have a high rate of thrombosis and adverse cardiovascular outcomes. And there's a lot of different reasons for that. The exact mechanism or mechanisms are not entirely elucidated at this point, and this is a particular interest of mine to try to better understand why these patients develop clots. We do know that there are a number of factors that seem to play important roles. These include older age. Most of these patients tend to be older, but not always. We know that certain things like inflammation, because of the cellular turnover, there's overproduction of tissue factor-bearing microparticles, which are very important for stimulation of the coagulation cascade and ultimately thrombin formation. Abnormal platelet activation and leukocytosis with neutrophil activation, all of these seem to play roles with regards to increasing risk for developing thrombosis. There's some things that are very interesting, I think, are the fact that there are likely endothelial changes that also increase risk for thrombosis. These patients seem to have a propensity for developing blood clots in the splanchnic vessels. We don't quite know why that is, but it seems that there are specific endothelial changes that may predispose to these patients developing blood clots in the portal vein, the splenic vein, superior mesenteric vein, or having Budd-Chiari syndrome. The other thing is that specifically the JAK2 mutation seems to play a role in terms of why these patients develop blood clots. So patients who have essential thrombocythemia or myelofibrosis that are JAK2 positive, as opposed to the differing driving mutations with calreticulin or MPL, they are more likely to develop blood clot than the patients who are JAK2 negative. The other thing that we know is that patients who have the JAK2 mutation, the higher the allele burden, the more likely they are to develop a clot. So there's data to show that if the allele burden is over 70%, those patients are more likely to develop a blood clot than patients who have a lower allele burden. How exactly this sort of plays a role, again, that's not exactly known at this point in time, but is the focus of some interesting stuff going on. Now, how common is thrombosis in myeloproliferative neoplasms? It's a little bit debated, and depending on what you read, you get a little bit of a differing frequencies, but somewhere about a third, anywhere from about 20 to 50% or so will report abnormal blood clotting. In one pretty large prospective study, adverse cardiovascular events had the highest contributor to mortality. It was about 45%. Compared to only about 13% that had transformation to a more aggressive hematologic disease like leukemia. About 2/3 of the thrombotic issues happen either at the time of diagnosis or precede the diagnosis. So it's pretty interesting that a lot of these patients may have a clot that's related to, again, the JAK2 mutation, but yet not yet be manifesting any signs or symptoms of a myeloproliferative disorder otherwise. Their blood counts may be normal. And what kind of blood clots do these patients have? So it's a little bit all over the place. In one prospective study, relatively recent prospective study, of the patients who had a clot, and that study was about 30%, 33% had a clot, 30 of those were venous thrombosis, 25 to 30% were acute coronary syndrome, 20% were stroke, and as I mentioned, 15% had splanchnic vein thrombosis. And that's a much higher rate than you'd expect for VTE otherwise. The 15% of patients who have VTE, it's not because of a splanchnic vein thrombosis. So again, we're not exactly sure why patients with particularly JAK2 mutated MPNs have splanchnic vein thrombosis, but we do know that if someone comes in who otherwise does not have evidence of an underlying myeloproliferative disorder, it would behoove us to actually look for this with screening for the JAK2 based on pretty good data. So this was a meta-analysis of 24 studies over 3,000 patients where they took patients who came in with otherwise unexplained splanchnic vein thrombosis and they screened for the JAK2, and the overall frequency was 32%. And that gave an odds ratio of 54 in this group of patients of finding a JAK2 mutation. And that does make a big difference with regards to how we follow these patients and what they can expect short and long term. So in clinical practice, a lot of us have adapted the policy or the practice of checking for the JAK2 mutation in patients who otherwise their blood counts may look okay, but they have an unexplained either Budd-Chiari or portal vein thrombosis. Oops. In terms of what risk factors for thrombosis, for both ET and PV, they both have higher rates of thrombosis than myelofibrosis. Myelofibrosis is about maybe 7 to 10% of patients will have some sort of a thrombotic issue. It's much higher for ET and PV. In terms of individual risk factors, age and prior thrombotic history are risk factors for thrombosis in both ET and PV. For ET, other cardiovascular risk factors and, again, the presence of the JAK2 mutation as opposed to having the calreticulin mutation or MPL mutation is an adverse marker for developing thrombosis. You'll notice that for ET, you don't see platelet count. There's been a lot of different studies that look into whether or not elevated platelet counts actually correspond to an increased risk for thrombosis. And in fact, the data shows that it really doesn't. So we focus a lot on the platelet count. We give patients cytoreductive therapy. They were worried because their platelet count's 800. But in fact, the clinical data shows that it really doesn't correspond to a significant risk for thrombosis. In fact, there's data to show that abnormal platelet counts, particularly extreme thrombocytosis, platelet counts over 1,000, there's actually a much higher risk for bleeding complications, probably because those platelets are not functional. For those patients with ET who have low risk with these features, the annual thrombotic risk is estimated to be about 1%, but it goes up to 3.5% for high-risk patients. For PV, younger patients, annual thrombotic risk is about 1.8, and it goes over 5% in patients who are over 70. Bleeding is also a concern, not quite as frequent, and typically not terribly severe, but it is something that we do see as well. Again, not entirely clear as to why these patients have bleeding complications, but there are some features that we know contribute. For example, development of anatomic issues, gastric and esophageal varices, either because the patient had a prior splenic vein thrombosis and that led to secondary portal hypertension, or these patients do develop massive splenomegaly, and that massive splenomegaly may cause secondary gastric and esophageal varices. For myelofibrosis, those patients eventually will become fairly thrombocytopenic. That will add to bleeding risk. But, as I mentioned, there can be qualitative abnormalities with platelets that lead to them not being functional, and those patients have bleeding complications. One of the ways that this can happen is through development of acquired von Willebrand syndrome. So as the platelet count gets higher, these platelets can adhere von Willebrand's protein, and then therefore the von Willebrand's protein is not available at sites where it's needed. In terms of how common is bleeding in MPN, rates vary somewhere between 8 and 16%. Some of the more common things we see when patients do bleed, it's typically an upper GI bleed, often but not always from like an esophageal variceal bleed. In a retrospective study we did a couple of years ago, we found the bleeding rates to be about 16%, and acquired von Willebrand disease was found in 18% of the patients. When we did a multivariate analysis, we found that age and extreme thrombocytosis were really the only risk factors for bleeding, with other things like mutational status, white blood count, or other blood count abnormalities not corresponding to an increased risk for bleeding. So returning to our gentleman, so we talk about thrombotic issues and potentially bleeding problems, and he's very worried about this turning into leukemia or because he has PV, myelofibrosis, so he wants to understand what his risk is for that. Blast transformation with ET, PV, and MF are illustrated here. So the blue is MF, the green is polycythemia vera, and the red is essential thrombocythemia. But in this study, at 20 years, 3.8% of patients with ET, 6.8% of patients with PV, and 14% of patients with MF ended up developing myelofibrosis. Ended up developing acute leukemia. So while it is a concern, it's definitely higher than the general population. The overall rate is still relatively low and much lower than, as I mentioned, the thrombotic risks. For patients with ET and PV, myelofibrotic transformation occurs in 10% of ET patients at 20 years and somewhere between 12 to 21% of PV patients. Why do these patients transform? Well, the most likely thing, and at least the thing we know most about, is the acquisition of additional abnormalities, again, mostly in the epigenetic modifiers and spliceosomes. So as patients acquire additional mutations in TET2 or the ASXL1, EZH2, they're more likely to transform into a more aggressive disease, and they may initially manifest myelodysplastic features, and sometimes they just go right on to acute leukemia. And patients who have secondary leukemia from MPN typically have a pretty poor prognosis. So lastly, he wants to talk about overall survival. What can he expect from here? Unfortunately, patients with these diseases do not live as long as matched controls. So the red line is essential thrombocythemia, green is PV, and the blue is MF, with the black line being expected survival for matched controls. For all comers, overall survival with ET is around 20 years. With PV, it's about 14 years. And with MF, it's about 6 years. But there are definitely things that influence how patients do short and long term. As I mentioned, mutational status plays a significant role with prognosticating patients with MF, less so with ET, and of course it's kind of a moot point with PV since all the patients with PV, which is the black line, have the JAK2 mutation. But for ET, whether you're CALR mutated or JAK2 mutated, the median overall survival is around 19 to 20 years. With MF, if you're JAK2 mutated, median survival around 5 years, but if you're CALR mutated, the median survival is estimated to be around 15 years, so it makes a big difference. And this is important to consider because the MF patients, we know that since they don't typically do as well long term, the only disease-modifying treatment that we have available at present is allogeneic stem cell transplant. So you may be more likely to take someone to transplant who may have for example, a JAK2 mutated MF versus someone who has a CALR mutated MF, but we'll talk about this more in a few minutes. In terms of prognosis, you'll see a similar theme here. These are all based on multivariate analyses that were validated with prospective cohorts with the ET, PV, and MF. But age, white blood count, and prior thrombosis are adverse risk factors, especially for ET and PV, and two of these also for MF. For patients who have low-risk disease, so if you're a young patient, normal white blood count, and no prior thrombosis, median survival not reached. So these patients do exceedingly well. Even for patients with intermediate risk, their median survival is 25 years. So these patients typically do quite well. As opposed to those patients who would be considered high risk, their median survival is estimated to be about 14 years. For PV, again, age, white blood count, prior thrombosis. Again, this is a completely different study. They found the same exact adverse prognostic markers in multivariate analysis. Again, for low-risk patients, median survival almost 30 years, and high-risk patients down to 11 years. It gets more complicated with myelofibrosis. And again, the driving mutational status does play a much more of a role with regards to how these patients do. So for the patients who do the worst are those patients who have myelofibrosis that are triple negative. They don't have the calreticulin, the MPL, or the JAK2 mutation. Median survival for those patients is only 2.5 years, as opposed to, as I mentioned, CALR mutated, it's 15 years, with MPL being around 10 years and JAK2 being around 5 years, 6 years, 5 to 6 years. So again, this may make a big difference with how you approach these patients in terms of treatment and follow-up. Much like the PV and ET prognostic models, there are also, besides the driving mutation, there are also individual patient factors that can influence how these patients do. Again, age and white blood count. With each of these diseases, you'll notice that the white blood count threshold gets higher. So with MF, it's 25. But those are consistent adverse prognostic markers for this class of diseases. In MF, anemia, Circulating blasts and constitutional symptoms are also adverse prognostic markers. And for patients who are considered low risk, their median overall survival is 135 months as opposed to 27 months at high risk. This has been an ongoing revision with this prognostic model. So the DIPS Plus score adds platelet count less than 100,000 transfusion requirement and unfavorable karyotype to the prognostic marker, to the other markers. And again, when you add these in, low-risk patients, 185 months median overall survival versus only 16 months for those patients who are considered high risk. So they are redoing this, adding in other driving mutations, some of the ones I've already mentioned. So lastly, in the last few minutes here, I'm going to talk about treatment for these patients. Unfortunately, at this point in time, short of an allogeneic stem cell transplant, we do not have any therapies available that would be considered disease-modifying. All we have are ways to hopefully lower the chances of them having complications, thrombotic complications, helping control their counts, and helping control symptoms. But we do not have any disease-modifying agents at this point in time. For patients with ET and PV, the main focus is to manage their symptoms and reduce the risk for thrombosis and hemorrhage. If we had any therapies available to prevent or delay transformation to myelofibrosis or leukemia, we would use them, but we don't at this point in time have those kinds of therapies available. So we really are focusing on reduction of complications. So for both PV and ET, we recommend aggressive management of cardiovascular risk factors. For all PV patients and for ET patients that are JAK2 positive, we do recommend low-dose aspirin, just 81 milligrams of aspirin a day. In patients who would be considered otherwise low-risk ET that are JAK2 negative, you could argue they don't necessarily need low-dose aspirin, although the downside is pretty low. For all PV patients, we do recommend aggressive phlebotomy with a goal hematocrit less than 45%, and that's based on data I'll show you in a minute. What's a very gray area is who and when to start cytoreductive therapy and which agent to use for that matter. We typically reserve cytoreductive therapy for patients who are either intermediate or high risk because the low-risk patients oftentimes don't really need it. In terms of which agent we use, the first-line therapy is oftentimes hydroxyurea, but there's some debate as to whether or not interferon should be used in younger patients as they may do better. However, there's no clinical data or evidence to confirm that that's actually the case. For PV, for second-line therapy or for patients who have symptomatic splenomegaly or other symptoms, we do have the availability of ruxolitinib. It's subject of an ongoing study in the essential thrombocythemia, but the study was complete in polycythemia vera. Ruxolitinib is a JAK1, JAK2 inhibitor that has been shown to be effective at controlling symptoms and blood counts in PV. So the reason why we use 45% as a cutoff for phlebotomy in patients with polycythemia vera is based on data from the CYTO-PV study. So this took patients who had PV and randomized them to what would be considered a low hematocrit target of 45% or less, or a high hematocrit target of somewhere between 45 to 50. And the primary endpoint of composite time until death from cardiovascular causes or major thrombotic events occurred in 10% of the patient on the high hematocrit arm and only 2.7% of patients on the low hematocrit arm. And interestingly, if you look at the median hematocrit for these two groups of patients, for the low hematocrit it was 44% and the high hematocrit was 47%. So that little difference seemed to make a big difference with regards to clinical outcomes. In terms of total cardiovascular events, again, those patients randomized to the low hematocrit target that occurred in 4.4% versus 11% in the high hematocrit arm. So we do recommend for patients with PV really we try to be as strict as possible to get patients to less than 45%. Now, ruxolitinib was studied in polycythemia vera. As I mentioned, it's a JAK1, JAK2 inhibitor. The composite endpoint of this study was at least a 35% reduction in splenic volume and better hematocrit control, so better control of blood counts. The composite endpoint occurred in 21% of the patients who were on ruxolitinib versus essentially none, about 1% of the patients on standard therapy. When they broke out the two endpoints, 38% of the patients on ruxolitinib had splenic reduction, and 60% had better hematocrit control versus essentially none in the control group and 20% in the standard therapy arm for hematocrit control. One of the things that I will say that oftentimes these patients do have symptomatic splenomegaly, and splenic reduction may have secondary benefit both with regards to lowering portal pressures as well as controlling blood counts a little bit better. But the big thing actually I think for what matters to patients besides those features is the fact that people feel better on it. As I mentioned, because the driving mutations lead to constitutive tyrosine kinase activity, these patients oftentimes have these constitutional symptoms of fever, fatigue, weight loss. They have night sweats and so forth. Pretty much across the board, patients who were on ruxolitinib had reduction in those kind of symptoms, whereas those patients on the standard therapy arm had no change or worsening of those symptoms. And that's the same thing we saw with the use of this drug in myelofibrosis. Now, myelofibrosis is a whole other category, and it's very difficult to treat. These patients typically are very symptomatic, have large spleens, have conflicting blood count issues. They may have really high white blood count and you'd want to use cytoreductive therapy, but at the same time, they're also thrombocytopenic and anemic, which makes it very difficult. So it can be very difficult managing these patients. And again, we don't have any therapies that we know are disease modifying. What we have is just stem cell transplant. But for those patients who are young, otherwise doing well, and have favorable features, their DIPSS score, those clinical features are favorable, and perhaps they're CALR mutated, they may do well for 15, 20 years without needing any intervention at all. Very different than someone who is triple negative, may have another driving mutation like ASXL1, and have significant abnormalities with their blood counts and their spleens enlarged. For those patients who are sort of in the middle of the road, they're not quite sick enough to need a transplant, but yet they are having some symptoms and some complications. Currently, the first line we typically use is ruxolitinib, particularly if they have splenomegaly and constitutional symptoms. So the COMFORT-1 and COMFORT-2 studies looked at this JAK1, JAK2 inhibitor in myelofibrosis. The COMFORT-2 was an open-label study. Their primary endpoint was splenic reduction, and that occurred in 28% of the patients on ruxolitinib. And you can see that pretty consistently splenic volume reduced in patients on ruxolitinib versus no change in best available therapy. But again, very importantly, patients felt better. So their global quality of life improved. The orange is ruxolitinib compared to best available therapy, and their functional capacity improved as well. And then individual symptoms, constitutional symptoms, again, on ruxolitinib, reduction in those symptoms versus no change or worsening if they were on best available therapy. This is very similar to what they found in the COMFORT-1. The COMFORT-1 was a double-blinded study using a placebo control. They had the same endpoints. Splenic reduction occurred in 42% on ruxolitinib versus none in placebo. And again, patients felt better. Their constitutional symptoms, individual constitutional symptoms pretty much across the board. You had reduction versus universally worsened on best available therapy or placebo in this case. And their total symptom score, you had improvement with ruxolitinib versus no change in the placebo arm. So it's great. Ruxolitinib's great. We do have something to help people feel a little bit better. The problem is that, again, it's not disease modifying. We don't have anything to say that it reverses fibrosis in the marrow. And we also know that about half of the patients will lose their effect by about 3 years. So right now, the only thing we have available is allogeneic stem cell transplant. The problem is that there's a significant amount of morbidity and mortality associated with allogeneic stem cell transplant. So we want to, first of all, identify patients who may have favorable risk factors such that they won't have as much toxicity with the transplant. And number two, identify patients who actually may get some benefit from it. Because there have been studies where they took patients with low-risk disease with MF and they took them to transplant early, and those patients actually did worse than patients with low-risk disease who just received best available therapy. For the first part of when we look at those two questions, who are good candidates in terms of toxicity, who are good candidates in terms of benefit, for toxicity, we look at age is not an absolute indication or contraindication, but at least physiologic age is something we look at. And with that, performance status and whether or not they have a lot of comorbidities. If none of these are present, they're less likely to have complications with the transplant, and they may be better off with the transplant because of the potential for cure. Now, that said, we also want to make sure that they may get some benefit. The patients who are going to get more benefit are those patients who have features of the disease that show they're not going to do well in the short term. So those would be patients who are triple negative, or if they've acquired new mutations in those epigenetic modifiers and spliceosomes that I mentioned, and therefore they may have a high risk of leukemic transformation. We say, well, geez, this person, they're probably not going to do well in the short term, and they're younger and they don't have a lot of comorbidities. We probably should go ahead and proceed with a transplant. As opposed to if they don't have those and they have other features that are concerning for developing toxicity, they may be better off with getting the JAK2 inhibitor that's available now, or we really encourage people to go on a clinical trial. And right now, I looked just yesterday at clinicaltrials.gov. There's about 430 ongoing studies with myelofibrosis, many of which are interventional studies with newer agents, either new JAK inhibitors or other inhibitors in the pathway like PI3K inhibitors, JAK1 inhibitors, and so forth. All of this is a relatively moot point if there's not a well-matched donor. We know that we need to have a good histocompatible donor, otherwise the patient's not going to do well. So selection of patients who would be best served on transplant can be very tricky as well. So with that, just to summarize what we reviewed today, so myeloproliferative neoplasms, they're characterized by overproduction of functional, mature myeloid elements. They have an identifying allele that's an acquired allele that drives the disease and the clinical manifestations. These patients with ET, PV, and MF have shortened overall survival to age and sex-matched controls, knowing that patients with ET oftentimes do fairly well for a long time. MF, it really does depend somewhat on the driving mutation. Thrombosis is the most common complication, particularly of ET and PV, with bleeding, fibrotic transformation, leukemic transformation. Those are other things that are complications of this disease as well. For PV and ET, the treatment is really focused on symptom management and reduction of cardiovascular outcomes and thrombosis. We have a number of different agents we used, phlebotomy for all PV patients, aspirin, low-dose aspirin, anagrelide, hydroxyurea, interferon. And again, which of these agents is best in particular settings really at this point in time still is not entirely clear. For myelofibrosis, we do have a lot of therapies and interventions that can be supportive, but really at this point in time, the only thing that we have that's curative is stem cell transplant, and that's really reserved for very specific groups of patients, knowing that the morbidity and mortality can be pretty significant. And so with that, I'm happy to take any questions. I'm sorry I had to rush through it. I'm happy to take any questions people have.
Do you have any questions from the trainees?
Sorry, not a trainee, but Brandon, I wanted to ask, and especially with PV, it's a disease that we so beautifully understand that's a signal transduction disease. And yet these JAK2 inhibitors, or at least ruxolitinib, has been kind of disappointing as far as you mentioned, it's not disease modifying. It seems like why is that? There's something missing. Is the inhibitor not good enough, or is it that pathway too side effect ridden when you hit it, or have we not had enough follow-up to see that it's actually disease-modifying? Maybe there's less transformation over time?
I think, that's a great question. And I think for PV, part of the issue is what you just said, is that because those patients typically do well for years, it's hard to know whether or not it actually does make a difference. I will say that in PV compared to MF, the response rates are, those patients who respond, the response rates typically aren't lost. Like half of the patients aren't losing their response at 3 years. These patients are the patients who respond, which is typically 90+%, respond for long, long periods of time. But in terms of why it's not disease modifying, there's a lot of theories. One is that the inhibition is not as good. It's not a selective inhibitor. It's a JAK1 and JAK2. Unlike Gleevec for the tyrosine kinase inhibitor we use for CML, the association with the mutation is not as good, so it's not as strong. And there are still downstream activations that are not being, that there's still some sort of breakthrough stimulation of the STAT pathway and the PI3K pathway, which is the reason why a lot of the clinical trials that are, especially in myelofibrosis, but also in PV, they're actually doing more of a dual blockage. So they're using a JAK1 inhibitor with the ruxolitinib. They're using a PI3K inhibitor with ruxolitinib. They're using there's a STAT inhibitor that's with the ruxolitinib. So they're doing combinations to see if that actually does make a big difference. But I think it's that it's good for symptom control, but it's not strong enough, I think, to really make a difference with how the disease does in the long term.
You presented a patient with erythrocytosis and a low erythropoietin level, and then you went on to show results of echocardiograms and ultrasounds. So the low EPO level implies that the problem's not EPO-mediated. Are you implying that you would routinely do those other tests in a patient like that?
And just for the sake of the format of a talk like this, okay. I put those up. But that particular patient actually had an echocardiogram. I did not order that. The abdominal ultrasound, you could argue he doesn't even really need it. But for most patients, for most of these patients who come in, when you do a workup like this, I usually start with, the ideal thing would be to do, probably the best first step is to get an EPO level. Repeat the CBC and get an EPO level, because as you point out, if it's elevated, then it's likely a secondary cause, and then you go down that pathway of getting the abdominal ultrasound. Is there any problem is there a renal lesion? Get an echocardiogram. Is there pulmonary hypertension? Get the sleep study. Is there any problems with sleep apnea that could be driving this? I will say that not infrequently, or fairly frequently, we see these levels that are not elevated, but not really suppressed either, like 10 to 15, and you say, maybe, maybe not. In which case, sometimes we do, because the JAK2 mutation is so easy to get, although it's expensive, and it comes back within a week, that's a very good way, because it also has a very good negative predictive value. As I showed, 95+% of patients who have PV will be positive for that mutation. So if it comes back negative, it's very unlikely that they're going to have PV.
What's the half-life of EPO?
Yeah, I don't know. It's a good question. EPO. I think.
Pardon? We've had radically different levels when someone orders it and doesn't know the other person has ordered it on the same day. If you get a low one like that, that's a miracle.
Yeah.
Except in renal failure.
Yeah, except in renal failure.
I was thinking that this is secondary.
Yeah. Well, and I would say that, when it comes back, I would say when the EPO level comes back definitely high, like if it comes back at 50, 60, you say it's not going to be, it's kind of going to be a secondary. If it comes back really low, then.
I've seen that with JAK2 positive. I just don't think we can hang our hat.
True, but at least from a screening perspective, yeah.
Brandon, all the mutations that you showed that are associated with these diseases are, of course, the same mutations we see in clonal hematopoiesis, which has no pathology but is almost certainly the forerunner of this. So, first of all, are we at the point where we should be prospectively evaluating patients when they hit about age 50 or so to see if they look like they're heading this direction? And then the associated issue is these are all things that are associated with chronic inflammation. So is there a known clinical association between chronic inflammatory conditions and the elicitation of these types of disorders?
So for the first part of the question, so just to understand, are you asking, should all these, it's like around like 50 years old, should people just be screened for JAK2? And or any kind. And I think that that's a really a murky area. Well, I mean, that it's a very murky area at this point when we have these CHIP diagnoses, clonal hematopoiesis of indeterminate prognosis, or other sort of like these abnormalities that we're not quite sure if they mean anything, or if it's going to necessarily manifest into some sort of pathologic process, or is it just some sort of predisposition? I think personally, I think at this point in time we don't have enough to say that we should be screening, especially if their blood counts are okay. And there's a lot of patients we see in clinic all the time that will have a mild cytopenia, and they're say, well, they could have some sort of underlying problem, but it's been present for a long enough time. So identifying it, if we have that sort of lead time bias, does it really make a difference if we sort of put a name to it or if we just watch it? From a research perspective, yes, but from a clinical perspective, maybe not as much. And for the second question was inflammation. Yeah, I will say that for the MPNs, there isn't anything to say that patients who have some sort of underlying chronic inflammatory condition are more likely to develop this. And there's actually a lot of young people who are otherwise healthy. And I have a fair amount, I'd say probably around like 15 patients who are 30 or under, no other medical problems, and they have the JAK2 mutation, they've had clotting problems. Those patients, I think, probably do have another sort of probably another allele that sort of predisposed them that we just don't know what that is. Because it's just odd that there's such a disparity with age, because we have a lot of young patients at 18, 19 years old. Why would they develop this somatic mutation?
You mentioned that 2/3 of the thrombosis occurs before the diagnosis is made, and particularly are suspicious of splanchnic thrombosis to the point of recommending JAK screening when that occurs. Are those people that get splanchnic thrombosis without a diagnosis yet made, do they have erythrocythemia, or can they have normal?
A lot of times they don't. A lot of times they don't. And it could be for a couple of reasons. The patient may have a splanchnic vein thrombosis with a secondary esophageal variceal bleed. The clot may have been there for a while, and they developed varices and they bleed. And with the bleeding, it masks the erythrocytosis. I will say that for the patients in my experience, in my clinical experience, most of the patients who've had like Budd-Chiari or some other blood clotting problem, they end up being JAK2 positive, kind of found incidentally, because their counts aren't significantly abnormal. Eventually, within 1 to 3 years, they do start to show erythrocytosis, leukocytosis, thrombocytosis, or all three.
I don't have time for more questions, but thanks very much. Very informative.